May I ask the chairperson of the session, Dr. Walid Al-Harz, to take his seat on the stage. Thank you again.
Good afternoon, everyone. I would like to thank the organizing committee for their activities in working up a good program and inviting good speakers. This is the second session. The first lecture will be presented by Dr. Ahmad AlKhabaz about recurrent infections, one infection too many. As we all know, recurrent infections or infections in general common in pediatrics. Many physicians, many pediatricians, they don't find themselves comfortable in dealing with such patients. When to refer them to specialists? Should we send them to ENT specialist? Should we send them to immunologist? Should we do the workup ourselves? I hope Dr. Ahmed will enlighten us about all these topics. Dr. Ahmed is a graduate of Newcastle University in the UK. He has completed pediatric residency at McMaster in Canada, then his fellowship in allergy and clinical immunology too. He has extensive research activities in dealing with difficult asthma, effective nutrition, food allergy and immunodeficiency. Dr. Ahmed has been a speaker in multiple local and regional conferences on the topic of food allergy, eczema, rhinitis, drug allergy and asthma, and currently he's a consultant pediatrician and specializes in allergy immunology at Mubarak Hospital. Ahmed.
Thank you very much, Walid. Assalamu alaikum and good afternoon, everyone. Thank you for joining this session today. I'm going to try to talk as clear as possible. The topic of immune deficiency is a complex but very interesting and well-developing specialty. And we are really honored to have Walid here as well because he's a pioneer in the area of primary immune deficiency in the region in Kuwait. I'm going to talk about a few things. Normal immunity, about when to suspect primary immune deficiency, about management and diagnosis, and some take-home messages, especially about when to consult the service and what to expect. Why need the diagnosis? It's quite obvious. We need the diagnosis because we have complications, and these include recurrent infections, autoimmune disorders, damage to end organs like the heart, the lung, nervous system or digestive tract, slowed growth and failure to thrive, increased risk of cancer, death from infection. And in many primary immune deficiencies, the presentation could be early on, and the management is involving bone marrow transplant or stem cell transplantation. And the earlier you have that, the better it is for prognosis and survival as well. So the immune system maturation. A few concepts here, because many people don't differentiate between immune deficiency and immune compromised. And that's the objective of this slide. So, immune compromised, see if that works. Sorry, I think it's not showing, just on my hand. Anyway, immune compromised are patients who have recurrent infections for reasons that are not related to their genes mostly, and due to other, let's say, secondary causes, whatever that cause may be. But when we talk about immune deficient patients, and we talk about especially about primary immune deficiency, we talk about people who are born with genetic defects resulting in immune compromised status and recurrent infections. All children are immunocompromised. This is a major statement, and that's an important statement as well, because the immune system goes into maturation from birth until we are an adult. Immune mature system, we have many children have recurrent infections, and that's considered to be normal in the young children. We know that the adult immune system is achieved by around 12 to 14 years of age, so until that time you're actually immunocompromised. And we know that infections and vaccines add immunity to those children, and that multiple antibiotics and less infections actually, in fact, lower their immunity, even though there's a misconception that if you have recurrent infections as a child, you probably are immune deficient. Prematurity is an important component as well. We know that prematures are increasing, and they have low maternal IgG transfer from the third trimester because of prematurity. They have C-section antibiotics as well, and lack of exposure to normal flora, and they may not be properly breastfed, so they don't have IgA protection in the colostrum. They can have higher congenital abnormalities, and in the immune sense, they have an inadequate immunity. They have less monocyte polymorph neutrophil number and function. They have low production of cytokines and impaired T cell activation, and they have intrauterine inflammation-induced immune tolerance. The baby in the womb does not need to have immunity. Otherwise, the immunity of the baby will fight with his mother's immunity. So they are actually made to have low immunity and not to have active immune system in utero. Otherwise, it's going to be a miscarriage. And again, stress-induced cortisol and steroids given pre-delivery may suppress the immunity in this case. This is a slide to show you different variations of immunoglobulin levels. You can see the IgG, IgM, and IgA, and IgE. This is from cord blood at term. The IgG level is equal almost to the maternal IgG, okay? But then you have higher IgM and moderate IgA and little or very little IgE. But then you get to the reach between 3 months and 6 months, you have the lowest level of immunoglobulin in the baby. And this is an area where we expect the baby to have protection from the mother, but they're not able yet to produce their own antibodies. So that's why they are normally immunocompromised. They're not immunodeficient, but they don't have proper immunity, okay? And you only by the time around 9 to 10, you get around normal level or near normal level, around 1,000. And the same for IgM, and the same for IgA and IgE. So adult levels only achieved by around 12 years of age, okay? This is a diagnosis which I'd like to share because of this certain phenomena that we have a transient hypogammaglobulinemia of infancy, which is a diagnosis made with children who are otherwise healthy, who have suboptimal or beyond, like under the range of expected standard deviation for those children. So they're relatively common primary immunodeficiency within the realm of primary immunodeficiency. It's an exaggerated physiological norm because normally we expect those babies to have low IgG anyway at around 3 to 6 months of age, but they have an extra low levels of IgG. Sometimes the IgA and IgM are normal or low as well, and it has to be diagnosed above 6 months of age because below 6 months of age, it's not unusual to be quite low. It's a diagnosis of exclusion, but when you test the function of the immune system, they have actually usually a normal immune function in that case, although they resolve usually between 2 and 6 years of age, and that's a transient condition. Some studies suggest that it may be actually a B cell defect, and it's within the primary immunodeficiency conditions that actually improve as we grow older, which is unusual because you expect primary immunodeficiency not to improve, but that's changing now in the paradigm at this time. Again, for T and B lymphocytes in serum, you notice at birth that we have a very high lymphocyte count, that's CD3 cells, okay, and we have CD4 and CD8 counts, which are high as well, but high CD19, and it tends to get lower and lower. So in fact, your lymphocyte count at birth is extremely high, and that's normal to have very high lymphocyte count. So if you have a child who's born with low lymphocyte count, you have to suspect primary immunodeficiency. Okay, and that's really an important take-home message today as well. If you have low lymphocyte count, especially under 1.5, let's say, or so, you have to consult with immunology service regarding this being a primary immunodeficiency. As we said, it goes down, and the B cells numbers goes down as well, and we have a ratio of 2 to 1 between CD4 and CD8 cells, which is important as well. Okay, so in trying to diagnose primary immunodeficiency, which is not easy, the Immunodeficiency Foundation suggested that you should think about the zebra. Now, that's a bit confusing. Why should you think about the zebra? We've been told in medical school that when you hear, you know, a horseshoe sound, you should expect there's a horse outside. Okay, that's the common conception, the common understanding. But immune deficiency is the zebra. So in fact, this horseshoe sound could be a zebra shoe sound. Okay, maybe it's unusual, but immune deficiency to be diagnosed, you have to think about the unusual, okay? Otherwise, you're gonna miss it. So if it sounds like a horse steps, think zebra, okay? Very cute zebra there, okay? So you have to think about the unlikely diagnosis. As you think about, with joint disease, you think about rheumatological problems. As you think about anemia causing hematological problems, you have to think that infection may be caused by immune deficiency, although immune deficiency is not only for infections, because immunodeficiency disease has an effect on the increased risk of malignancy and autoimmune disease. So it's an important concept as well. Recurrent infections is what we talk about today. Yes, they are caused by many things. Allergic disease increases your risk of recurrent infections, okay, because allergic disease impairs the mucosa. When you have impaired mucosa, then you have a higher chance of infections. And we know that many people who have recurrent infections have allergic disease, rhinitis or asthma. We know that cigarette smoke increases your risk of infection, whether it's maternal, second-hand smoke, or first-hand. We know that daycare, being a child in a daycare will increase your chance of infection. We know that chronic disease, whether cardiac, nephrotic, or otherwise drugs may increase your infection. Circulation problems like sickle cell disease, or when you have even wet lungs because of congenital heart disease, cystic fibrosis, obstructive lung disease, nutrition. Any nutritional abnormality will cause an impaired or suboptimal immune response, especially iron, vitamin D, zinc, and folate. A foreign body can give you recurrent infections and skin disease. So the first line of defense in the body is the skin. So if you have any chronic disease of the skin, you expect to have recurrent infections. If you have chronic allergy, then your inside skin, your mucosal skin is impaired, and you have recurrent infections because of that. Then you have primary immune deficiency. But you have to think about the complexity of all this, and you have to rule out all of that before you think about primary immune deficiency as well. This is the reason why we have infections, right? The initial immune responses are actually very slow. You see there the time and the first exposure to an antigen. You take some time to develop the first primary response, which is usually IgM, which is kind of a clumsy antibody. It's quite big and fat and not very strong or speedy. So it takes a long time to get to the infection. Then you have polymorph neutrophils, B cells, and complement. At that time, we don't have memory, we don't have specialized weapons. You can think about this as having your normal soldiers on the borders who don't have enough experience by seeing a new enemy, not knowing how to fight it, not knowing how to kill it. But you think about the second antigen response, then you see that the adaptive immunity takes over. You produce IgG, which is your fast targeted weapon. It's very strong, very fast, very specific. Then you have your T cells, memory T and B cells, natural killer cells, plus your primary immunity. So it's a more robust reaction, it's a stronger reaction and longer lasting, and it tends to affect the infection much rapidly. That's why many children are allowed to have a single severe infection. Because at the first exposure within a virgin immune system, you need time to adapt and time to recognize and time to take a picture and time to keep memory, okay? But on your second exposure, you should be extremely alarmed about that infection. This is the red flag suggestive primary immune deficiency. They are suggested by the Jeffrey Mandel Foundation. They are useful, but they should not be taken as the only reference. Okay, so in a child who has more than 4 new otitis media within the first year or within a year of life, 2 serious sinus infections within a year. Now, sinusitis doesn't happen in young children below 2 years of age, but it can happen older. More than 2 months on antibiotics with little effect. More than 2 pneumonias within 1 year, obviously confirmed with x-rays. 2 or more deep-seated or organ abscesses. 2 or more deep-seated infections during septicemia meningitis, failure to thrive, persistent candida oral or cutaneous, especially when you think about it beyond 1 year of age, or maybe more systemic, need for intravenous antibiotics to clear infection, and a family history of primary immune deficiency. And you need the family because the majority of primary immune deficiencies are either autosomal recessive, which is the bulk of those cases, or X-linked, although we do have some autosomal dominant cases as well. So the history and physical examination is really the most important component of diagnosing primary immune deficiency. Okay, so in approaching a patient with suspected immune deficiency, you need a complete history, including birth, vaccination, admission and surgery, chronic disease or medication, previous infections, types, severity, cultures, duration, admission, detailed family history, history of risk for HIV, hepatitis infection, failure to thrive, skin disorders, or a complete systemic review. So you have to do a complete systemic review to consider that. As I mentioned before, atopy is a risk factor, accounts for about 30% for recurrent infections in one study. Normal growth normally with atopy, a normal development, normal response to antibiotics according to age and severity of disease. And you can see in some cases with rhinitis, they have as much as 1/3 of chronic cases of chronic serous otitis media because of associated rhinitis as well, and can include complications as well with dermatitis or atopic dermatitis. Breaking the skin increases the risk of infection, and asthma patients do have more frequent pneumonia, and that's not because they are immune deficient, it's because they have an immune compromised status. The physical exam is a bit more complex because it's very, very variable between different children and different diagnoses, but Generally, the child could be sick or actually look normal. They could be dysmorphic or either normal as well. They could have lymphadenopathy or hepatosplenomegaly, like different diagnoses I mentioned here, or they could have actually no lymphadenopathy, I'll mention later. They can have different skin lesions, including abscesses, seborrhea, warts, molluscum, contagiosum, herpes, candida, or albinism, or absence of eyelashes or hair. They can have intractable diarrhea and malabsorption in some syndromes. They can have rheumatological autoimmune disorders or hematological, like hemolytic anemia or thrombocytopenia. In many diseases, they can have no lymphoid tissue at all and no tonsils in a different manner. So you can variable between having too many lymph nodes or no lymph nodes at all, and both could be immune deficiency. You can have purpura or eczema, like in Wiskott-Aldrich, and usually the eczema in those cases is usually resistant to treatment or can have granulomatous disease in hyper-IgA syndrome. Scarred tympanic membranes can be normal or can be immune deficiency in A gamma cases, oculocutaneous albinism, Shideki-Gages syndrome as well, or failure to thrive. Now, this is by all means not an inclusive list of everything. It just shows you that the physical examination could show you many abnormalities. The characteristics of infections are usually recurrent. If they have a persistent low blood count after the infection has cleared, if they have an unusual or less virulent infectious agent but still recurrent and becoming more severe as you don't expect to see in such a patient, such an infection, or if it's persistent, you have to consider a primary immune deficiency disease in these cases as well, and that's a recommendation by the Immune Deficiency Foundation as well. The next slide is slightly busy. I just want you to focus on one thing, that different disease syndromes have a different presentation skin. So Wiskott-Aldrich is eczema and petechiae, hyper-IgE can give you abscesses, the George syndrome can give you candida, CGD will give you abscesses which are deep and candida, ataxia telangiectasia can give you telangiectasia and photosensitivity or hyper and hypopigmentation, Grisel syndrome, Shideki-Gages give you mucocutaneous albinism, other deficiencies which are a bit rare, MCH, they're more common in Morocco, necrotizing granuloma, IPEC syndrome, eczema, and Omen syndrome, which is a special type of immune deficiency and SCID, will give you sometimes as well erythroderma, lymphadenopathy, as well, and hepatosplenomegaly. So, primary immune deficiency, a few points about primary immune deficiency in Kuwait. The prevalence is about 12 in 100,000 new cases per year. That's without the screening program at birth. And that doesn't include IgA, which is the most common primary immune deficiency, antibody in primary immune deficiency. This is done by a study by Walid some time ago, 2008, I believe. And we have a higher prevalence in consanguineous marriages, between 35 and 75%. In the last conference, the first Arab conference, primary immune deficiency in Morocco, the statistics were showing about 4 million cases diagnosed in the Arab world, about 81,000 new cases a year. In the US, with the screening program, we have 50 in 100,000 prevalence, which is actually 4 times the number we are diagnosing at this time. Okay, so if we had a screening program, we would detect 4 times the number of immune deficiency cases we are detecting at this time. Okay, so the classification of primary immune deficiency, again, a study by Walid and colleagues. There are 8 major classifications: combined T or B cell and B cell, predominantly antibody deficiencies, other well-defined immune deficiency syndromes like ataxia telangiectasia, the George syndrome, Wiskott-Aldrich, and hyper-IgE, disease of immune dysregulation, congenital defects of phagocyte number and function, defect in innate immunity, autoimmune and autoinflammatory disorders, and complement deficiencies. And this is an ongoing debate about the classification, which is still, I think, is developing even more and more, but it's important to keep that in mind as well. It's not only about infections. These are characteristics of the common ones. This is a basic really slide about what kind of component of immune system is affected commonly, the pathogen, the age, the site, and a clinical example. And I just want to highlight that the majority of immune deficiencies are B cells. You can see about 65% there. 20% or so are T cells, some phagocytic defect around 6%, and some common to 4%. That's obviously variable according to society and according to different populations. But different kind of infections can happen there. Even with B cell, you can get enterovirus infections, Salmonella, Giardia lamblia. So you don't think about just bacteria in B cell defects, even though we tend to think about Candida and opportunistic infections more in T-cell disease. The presentation of T-cell disease usually before 6 months of age in the majority of cases, while in B-cell it's usually above 6 months of age because of the protection of the maternal antibodies in the first 4 to 6 months of age. But phagocytic defect, 10 minutes?
2 minutes.
2 minutes, sorry, almost done. Okay. Complement can occur at any age. Okay. So these are just general recommendations. If you suspect immunodeficiency, avoid IM injections, avoid vaccination, live vaccines, avoid giving blood products. If needed, give irradiated, leukocyte depleted, CMV negative, and general hygiene and cleanliness and isolation if needed. So what's new with immunodeficiency? There are more than 150 types. They affect development and function of the immune system and have a higher prevalence in high consanguinity or among genetically isolated populations. Okay? This is a slide just to show you that we have different look now to immune deficiency. It could be more common than we think. It could happen as a sporadic rather than inherited form. It could persist into childhood, from childhood to adulthood. We expect people to be worse with immune deficiency, but they actually in some cases get better as they get older. You can have a single episode of infection that still be immune deficient in some cases. Okay, and in one study here, you see that invasive pneumococcal disease in children can reveal immune deficiency, even if they are vaccinated, and that's particularly in older than 2 years of age. Up until 26% could have still primary immune deficiency. And there's some new diagnosis about toll-like receptors, which in a single toll-like receptor, you can have a certain infection of herpes or mycoplasma or different infections. Okay? Immune evaluation involves numbers and functions. Sorry about that slide, it's not coming right. Okay, and you do evaluation by history, and you do a screening test by CBC, test for humoral immunity and B-cell count and antibodies against vaccines, and you do cellular immunity testing with lymphocyte phenotype and lymphocyte stimulation testing. Phagocytes as well, you do a CBC, you do IgE levels, and you do DHR, or a test of the oxidative burst of the macrophages. And with complement disease, you do CH50 assay and C3 and C4. In monitoring immune deficiency patients, we look for monitoring the immune deficiency compliance, frequency of infections, need to adjust medications, look for organ damage and end organ damage. You do radiological sometimes for confirmation whether they have an absence thymus or dwarfism or infection. You look for autoimmune disease and malignancy, and look for growth and development as well. Once you have a confirmed diagnosis, you need to emphasize on education, do boil water source unknown, avoid smoking, you do genetic counseling. Vaccination would depend on the case. Normally we don't give vaccination, but some cases may have some vaccines. IVIG, super immunoglobulins for specific disease like varicella zoster immunoglobulin. When you have a chickenpox infection, antibiotics tend to be aggressive, early, prolonged, and especially look for resistance for antibiotics, but prophylactically they can be used in B-cell defects. Enzyme replacement in SCID with ADA deficiency, for example, and hematic stem cell transplant in most cases. So this is the last slide. Okay, so when you need to refer to the allergist, immunologist, if you have family history of immunodeficiency, especially first degree, but that includes second and third as well, failure to thrive, candida, especially above 1 year of age, or systemic. If you have severe infections such as meningitis or sepsis twice a year, deep-seated infections, as we mentioned before, twice a year, pneumonia, sinusitis, otitis media more than 4, lymphopenia at birth, I highlight that a little because it's very important for screening. Vaccine-related infection, so you get BCG, then you develop BCGiosis, or you get polio vaccine, you get poliomyelitis, or you get any vaccine and develop the disease associated with the vaccine itself. And opportunistic infections you should consider, or if you need a long course of antibiotic to clear infection, and in special and specific syndromes. Obviously, you have to consider all these together in the picture of a single patient and not individually. That's the end of it, and thank you very much.
Thank you, Dr. Ahmed, for the nice and detailed presentation. I think this presentation should be divided into maybe 5 or 6, but you were able to condense it into one. There are 2 important messages here, I believe. The first one, not every patient or every subject present with recurrent infection is an immune deficient. And the second important message is that primary immune deficiency can be a mimicker of many diseases, since there is no specific presentation for the diseases. We're open for a few questions.
Thank you, Dr. Ahmed, for this excellent presentation. My question is related to actually the vaccination as well as the immune deficiency status. During the season, obviously, as pediatricians, we encounter a lot of patients who are coming with exacerbation of asthmas. So many of these patients encounter to use the systemic steroids. And sometimes we actually need to give them for a certain time of a week or 10 days. My question is, does this prolonged use of steroids warrant deferring vaccination? And if so, is it just related to the live vaccines or all the vaccinations? Thank you.
Okay, thank you for the question. You delay your live vaccines for a minimum of 2 weeks after you finish a course of systemic steroid that is short, like you mentioned, which is 5 to 10 days or something like that. And I didn't get your other, was there another question, sorry?
Is it just the live vaccines, or do we need to defer all the vaccines? I mean, is it just related to the immune status of the patient, or just also the immune response to the vaccine itself? It's
actually to both. I mean, with live vaccines, we expect them to have, I mean, this short course should not have a major impact. So just a precaution from the CDC to delay for 2 weeks. There's not enough evidence to suggest that you have a suppressed immune response, but that's the time needed for you to have return almost a week or two to return to your normal lymphocyte count and lymphocyte response at that time. It's just a precaution, and that includes both live and non-live vaccines. Yeah. Yes. Thank you, Anthony. It's very good to see you as well. I think one of our colleagues, Dr. Matham, is working on that. He worked on MAC as well at that time. It's still in early stages, and they are considering what kind of screening they do. They do TREC, or whether they do other components as well. But there is a plan that's started but not yet completed. Okay, thank you.
Yes.
Excuse me, I want to ask about the CBC with differential count. It will give us background for screening to rule out immune deficiency, and if we use it as cord blood sample, rule out or?
You mean CBC at birth or what?
Yeah, at birth.
Yeah. So
cord blood sample.
Cord blood.
Yeah.
No, cord blood. I'm not sure if we can use, but CBC from the baby by a prick, by Guthrie, or by a serum sample, it doesn't actually rule out immune deficiency. But as a screening tool, if you have significant lymphopenia of less 1.5, it's a major red flag for considering evaluation for immune deficiency. Only at birth.
Okay, thank you, Dr. Ahmed.
Okay, thank you.